right into my case report and open approach to primary posterior hernia repair. And from the study, we declare that there is no conflict of interest. And here is the outline of this topic. I have divided my presentation into 4 main parts. First of all, I will talk about breakdown and rationale. And second, we will look at case report. And third, I will talk about discussion. And finally, I will end with conclusion. My presentation will take about 15 minutes and we will have about 5 minutes for questions. And let me begin by giving you the breakdown and rationale. Why is it interesting? Posterior hernia was first described by French surgeon, the director of Royal Academy of Surgery, Paris, France, in 1738. His name is Jean-Louis Petit. He was the first person who described the posterior hernia. And posterior hernia are a rare type of hernia with only about 300 cases reported in literature. The incidence rate is less than 2% of all abnormal hernia, and they are usually found between 50 to 70 years old. They can be divided into congenital and acquired, which were 20 and 80% of lumbar hernia respectively. In addition, acquired hernia can be divided into primary and secondary. Primary lumbar hernia are more common, account for 55% of all hernia, and risk factors for primary lumbar hernia are obesity, connective tissue disease, and conditions that can increase in diagnosed patients. And secondary cause may be occur after trauma, infection, and previous frank surgery. Moreover, they can be classified by location into superior and inferior lumbar hernia, and these are the boundary of the hernia. First, the border of superior lumbar triangle are composed of 12 leaf superiorly, internal oblique muscle laterally, and cortical muscle lumbar medially. And second, the border of inferior triangle are composed of the iliac crest inferiorly, external oblique muscle laterally, and lateral dorsal muscle medially. And you can see in this picture, encapsulation is less than 10% due to wide neck defect. And it is an interesting case because the diagnosis is often missed because it's a rare case, and moreover, surgical treatment is still controversial. And both open and laparoscopic technique can be approached in this situation. So moving on to the literature review, if you look at this table, you can see the case series of posterior lumbar hernia, including descriptive articles published with more than 5 cases. They show the difference of etiology, type, location, clinical feature, and treatment. Now, please look at this table. I would like to show the detail of each patient or of patient per elective case due to the patient has reducible hernia. And the table shows information of author, sex, age, diagnosis, cause, procedure, follow-up time, and recurrence. And there are primary and secondary etiology. The secondary cause can be following surgery in the back. For example, following excision of lipoma, following spine surgery, following erect bone harvest. And there are open and laparoscopic surgery. In the literature review have found the advantage of minimal invasive surgery. There were less pain, short length of hospital stay, less wound complication, offer an excellent visualization. And we always use the mesh in elective case. If we do the surgery with our mesh, it can be recurrent due to tension. And there are multiple layers of mesh placement, including subline mesh placement. And this case, the surgeon do this inlet mesh placement and interperitoneal outlet mesh placement. And finally, after follow-up, they have not found the recurrence of hernia. Let's move on the interesting topic. This is my case report. A 74 years old female, her body mass index was 16 kilograms per meter square, and she had no history of trauma and previous surgery. Patient came to the emergency room complaining of swelling in the left lumbar region, and she had active chronic obstruction for 3 days. This picture showed the back part of the patient. The right side is head of patient and left side was foot. And the left right is 12 and the blue circle line is the mass. She has a palpable mass below the left 12. On examination, there was a 5 centimeter irreducible tender mass located in the superior lumbar triangle. So we did the CT scan. The red arrow side is the abnormality. There was a hernia bow into the posterior abdominal wall defect below the left 12. It contained part of descending colon, and CT scan was confirmed as left superior lumbar hernia. Then we decided to open transabdominal approach due to presenting with acute chronic obstruction. Intraoperative findings were found that the content of hernia was a part of descending colon located in the defect, and this is the point of obstruction. The then admissions were released medically and the colon was reduced completely. There was a one defect in superior triangle of 5 centimeters. Then we decided to use the polypropylene mask and it was placed in the pre-peritoneal space. Then closure the peritoneum covered the mask. Moving on to the discussion. The obstruct acquired primary superior posterior hernia was diagnosed in this patient. Developing of posterior hernia could be from the weakness of abdominal wall, following old age, and poor nutritional status. In general, they are usually reducible due to wide defect. But obstruct lumbar hernia was found in this case and might be resulted in bowel gangrene. And the bowel gangrene should be suspect in this patient due to tenderness on palpation. Therefore, we decide to emergency surgery because of the general right bowel dilatation and suspected bowel gangrene. The reason why we showed the open transabdominal approach. Finally, the chronic content was reduced into abdomen, followed by covering the defect with the prosthetic mask. And after 2 years follow-up, there is no recurrence. We showed the synthetic mask that's called polypropylene mask, and this is the property of the mask. The port size is 0.8 millimeter, and it is absorbable monofilament mask. It is a medium to heavy mask of 156 of tensile strength, and the advantages are fossilized fibrobascular in growth, infection resistant, and mask compliance is improved. But the advantage is adhesive free. And we show the supplement placement due to the mask may be achievable if we did the OLED intraperitoneal mask placement. Well, that brings me to the end of my presentation. We look at 4 main points in the circle. That being said, we should highly suspicious of posterior hernia, although it is a rare case. When an old patient with previous abnormality of the back encounter with posterior lumbar mass needs careful evaluation and highly suspicious of posterior hernia. CT scan remain the imaging study of choice, and operative planning is dependent on clinical of emergency or elective surgery and hernia site. Laparoscopic surgery offers an alternative method, and med placement is the predominant method of tensionless repair following the current principle of hernia surgery. At a final point to conclude, I would like to say from this session that the prevention is the most important. And please take a look at this flowchart as I said at the beginning. You can see that some etiology can be prevented. For example, increasing internal pressure and incisional hernia. And finally, we wish to acknowledge our institution Ethics Committee of Kalasin Hospital to encourage this report.